For pulmonary hypertension, there are various criteria available. I'm sure you are far away. I don't know myself. I rely only on you for echo finding that will give you diagnosis of pulmonary hypertension. And you may do further tests to rule out group 4, that is pulmonary embolism. Majority of the moderate severe pulmonary hypertension, if you have, the first would be because of pulmonary embolism. There are best tests available. You are doing DQ scan, or DQ scan off rate is not required with very good quality of CT scan. With good pulmonary angiograms on CT scan, you will be able to pick up thromboembolic disorders with great confidence. And if there are some further pulmonary arterial. So if you have to rule out group 2, with good echo, and if you have to rule out group 3, you will need lung function test, that is spirometry, maybe a blood gases, and a good CT chest will help you rule out other conditions, and pulmonary arterial hypertension becomes a diagnosis of exclusion. Allow me to share a few CTs where you will be able to confidently talk about pulmonary embolism. Unluckily, the pointer is not working, but there is an arrow. You can see that thrombus, which is there on the pulmonary artery, and it is there on the both sides. You could see that here also there is a thrombus there on the left image. You can see a saddle thrombus or vertical thrombus occupying the entire length of that vessel artery. You can see that polo sign here. You can see saddle thrombus here. If you do pulmonary angiograms, you can see plaque like here, and in situation where there is associated pulmonary infarct, the lung infarct, you may see a triangular wedge shape, or you may see even this kind of shadow, and on pulmonary angiogram you can see a block there. So if you do good CT scan, by and large you can safely rule out group 4, that is thromboembolic disorder. Last 2 minutes on pharmacotherapy. The pulmonary hypertension has got 3 pathways. You've got endocrine pathway, you've got nitric oxide pathway, you've got prostacyclin pathway, you've got drugs which act on different pathways to reduce pulmonary hypertension. And from the last 20 years, early diagnosis and appropriate treatment, or very aggressive treatment, has given you good quality life. Your pulmonary arterial hypertension average life will be about 3 years, but with good treatment, will give them a good quality life for 6 to 9 years. You would do risk assessment by ProBNP, RV, clinical failure, that is right heart failure, clinical judgment. You will do it with echo finding. You will do it with a functional class, that is 6-minute walk test. Presence of 𝐡𝐞𝐭 𝐁𝐚 would decide what kind of risk patient carries. So if patient 𝐡𝐺FR is fine, if his blood pressure allows you to give them a good treatment, if you have heart rate, functional class, 6-minute walk test, and BNP, keeping this parameters in mind, you could put patients on various risk, low risk, moderate risk, or high risk category.